Supplemental Anatomy Review, Session 2, Part 1, Amputations of the Foot and Ankle. Just real quick, some housekeeping for this week. Good job, you guys, on your palpations quiz and everything that you had with Miss Parker today, and I was the patient model. You guys all did a really good job of wearing gloves, so good job. But no, you guys did a really good job of treating me as a patient, very cautiously or gently. Um, I made each of you take my shoe off and take my sock off, and even though, we're all very comfortable with each other, you all made took certain precautions to ask me if you could, touch my foot, or you told me I'm going to take your shoe off, or you asked, would you like to take your shoe off? And you all were very cognizant of how to approach a patient. And I want to commend you all on that because I definitely was able to notice. So let's go ahead and get started real quick. Oh, here's a picture of you guys. Aren't you all adorable? It's like day one, you didn't know anything. Except Jermaine. You look kind of sad right here, Jermaine. I don't know what's going on. We should work on that. Anyway, but I remember that this time last year, for myself, this semester that you guys are currently in was one of the most difficult semesters for me. There's a lot of reading, a lot of classes that were all weighted the same, and it was hard to kind of prioritize them. So what I would suggest is really try to keep up with the reading. For me, I got frustrated because I would be assigned, 20 chapters to read and would never necessarily get quizzed on it. But looking at our board examinations list of recommended reading, the textbooks that we have are they're on that list. So anything from these textbooks are fair game. So although you might not be quizzed on these reading assignments per se, it's building your fundamental knowledge of the subjects, and it's stuff you'll see again when you're studying for your boards and preparing for them. So I know boards seem to be a long, far ways away, but I think it's important for you guys to have a positive outlook towards these readings. I know for me it was hard to get them done or hard to stay focused, so I made it a point to try to write down like one or two bullet points just from each paragraph so that I knew that I was keeping up to date with my readings and that I was actually comprehending what I was reading. So maybe some of you are a little better than that at that than I am, but yes. Okay, so try to keep up with those. Today we are going to look at amputation levels seen in the foot and ankle. I know you guys have already covered this with Dr. Childers, but we're going to run through it really briefly. Chapter 2 in your Atlas of Amputations and Limb Deficiencies talks about different ways an amputation can be performed. I really like this chapter though because it talks a lot about the medical techniques, and I just think it's interesting for us to know exactly how some of these amputation surgical sites are. I know that you guys have a lot to read, but chapter 2 might be a good skim for you. Dr. Childers will go more in depth on common surgical techniques that you need to be familiar with or understand. Alright, to begin with, it's important to understand the necessity of examining the foot throughout. So, due to a large majority of our patients having diabetes, circulation in the extremities is limited. So, patients with a loss of sensation or experience a loss of sensation due to high blood sugar levels. And these high blood sugar levels essentially cause damage to the nerves and blood vessels. So this causes a neuropathy, and a neuropathy is a lack of sensation. Frequently, a wound is going to develop on the foot, and the patient isn't able to feel the severity of the wound or even the presence of the wound. Typically, this wound will become infected, and that's when it becomes bad because the patient is unaware that they have a wound, the wound becomes infected, and because we have these damaged blood vessels and nerves, we have delayed healing. The blood vessels lack the ability to transport essential nutrients and white blood cells, our neutrophils, T cells, B cells, monocytes. These will be explained more in your neuroscience class, but the body is unable to fight the infection, and therefore the limb must be amputated. Additionally, you can see in this picture on the left is a more typical nerve and blood vessel, and on the right we can see the occlusion of the blood vessels and the lack of myelination on the nerve fiber. So if you remember from neuro, do you remember what myelination does? you might get to that, but it's pretty much the surrounding surface of the axon, or of the nerve fiber that permits the signal from traveling. So the myelination helps that signal travel down the axon of the neuron to the synaptic cleft. However, in a damaged myelin fiber, it causes the synapse to either be delayed or unresponsive or just messed up in general. So it really just depends on what the nerve type is, if it's a sensory nerve, if it's um, a motor nerve, depending on that. So you'll learn more about myelination and Schwann cells and everything, but just keep this in mind whenever you guys are going over that chapter. So again, if we have nutritional deficiencies and our oxygen perfusion is limited, so we're not getting enough oxygen to these distal segments, then unfortunately this can lead to amputation. And this amputation can, or this whole pathology of, occluded vessels leading to a wound that becomes infected, can happen more than once. So for patients with diabetes, this is often called the nibbling effect. And this is when multiple amputations occur, causing a more proximal or severe amputation each time. So what do I mean by that? It's a patient first receives an amputation just on the toe. So look in picture A right here. We just have the second phalange on their foot. You can see that there's infection in probably the bed of the nail. Maybe they dropped something on their foot and it made their toenail break and their nail never really healed. And so you can see that this patient has no hair on their feet, and that's commonly an indication that we're having a little bit of lack of oxygen in the area to be able to supply the foot. Also, there is a scaly appearance to these feet, so that's something very common. Patients with diabetes present very, very often with a dry or scaly looking foot because the epithelial cells aren't getting enough nutrients, they aren't getting enough oxygen, and pretty much like just nutrients down to the foot. So anyway, you'll learn more about that, or you should have learned more about that in anatomy, but that's not the purpose of this lecture. Anyway, so we look at picture B and we can see that was too infected and had to be removed. So this is the same individual again. However, you can tell that this has infection has increasingly spread. So they are probably going to have to get at least through the IP joint right here amputated, and then more than likely through the metatarsal phalangeal joint in this area. So probably, unless the surgeon would be able to save this great toe for stability purposes, this would be a MTP disarticulation or perhaps a transmetatarsal amputation. So if a patient isn't consistent in checking their skin, making sure they have properly fitting shoes, they're not going to know if they have injury to their foot. So we need to make sure that we are observing the patient's foot every single time, making note of it to see if we can prevent this nibbling effect from occurring. Because this essentially, if a patient's not careful, will lead to a partial foot amputation, which will easily lead to a transtibial or a transfemoral amputation, going up more proximal each time, which is something that we could hope to prevent by keeping a close eye on our patient. Right, let's see. Either way, let's look back. Okay, yeah. Either way, so sometimes we can try to salvage the limb. So a lot of people go through limb salvage techniques in attempts to keep their limb, which, you can't blame them completely because we enjoy our extremities, typically, I would say. So there's really good chapters in your book. Chapter 4 and 34 is going to talk more about amputations with the diabetic population, but chapters 4 through 6 talk about amputations due to trauma or to tumorous formations, and I think those are a good skim over as well to see where in a traumatic amputation, how much do you save versus how much do you need to go ahead and remove, depending on the severity, depending on the pain or anticipated pain. So, yes. Anyway, let's keep going. All right, we're going to talk about amputation levels. Quick clarification, it can either be an amputation or a disarticulation. Amputation is kind of a catch-all term, but typically an amputation passes through the bone and a disarticulation occurs through the joint. So you'll see amputation used pretty much interchangeably, but a disarticulation definitely occurs through the joint. So for example, there are amputations through the phalanges, but disarticulations through the interphalangeal joints. Okay. Either way, amputations of the phalanges or disarticulations of the IP joints, these are known as toe amputations. So we kind of have two different groupings. We have toe amputations and a partial foot amputation. So you can see here it's a toe amputation, classified as an interphalangeal. I would assume that the amputation of the third and fourth flange right here, this is probably an interphalangeal amputation. And then this great toe, do you think it's an interphalangeal amputation or an interphalangeal disarticulation, or do you think it's a phalangeal amputation? Okay, that was a really difficult way to word that. Anyway, these are my unsurgeon thoughts. To me, it looks like right here, we're going to have the head of the first metatarsal, and then there might be a tiny bit of our proximal flange on our great toe. So to me, this looks like a phalangeal amputation, but this could just be scar tissue swelling, an osseous formation, but that's kind of what it looks like to me. So anyway, that is going to be our toe amputations. Next, we are going to have a more proximal amputation to that known as a transmetatarsal. So transmetatarsal amputation is going to be our longest partial foot amputation, and just like the name suggests, it is trans or through the metatarsal bones. Typically, we'll want to leave this as long as possible so that the patient has a longer lever arm that allows them a little bit of push-off capabilities. All right, the next one is going to be the Liz Franck, or the tarsometatarsal amputation. This is essentially through the tarsal and metatarsal bones. But with this procedure, if possible, it's not shown in these pictures, but if possible, oftentimes a little bit of the base of the fifth right here is kept so that the tendon that attaches to it is maintained. Do you remember the name of that tendon? Fibularis brevis, or peroneus brevis. Peroneus brevis is going to insert on the base of the fifth right here. A lot of times the surgeons will attempt to keep this insertion point so that balance within the foot and stability of the gross anatomy within the foot remains. A lot of times also the peroneus longus and the tibialis anterior, they might try to keep they really want to try to keep intact that attachment point as much as possible. Okay, so the next one we are going to look at is the Chopart. This is going to be a transtarsal disarticulation that occurs through the talonavicular and calcaneocuboid joints. So essentially, we don't have any of our tarsal bones. We only have the hind foot left. Remember, so I'm sorry. We have two of our tarsal bones, calcaneus and the talus, but the rest are gone. Okay, so we have just our subtalar joint left, and none of these other ones with the cuneiforms or cuboid navicular, all that is going to be gone. Okay, so this is going to be the Chopart. And then now let's look at a Symes amputation. So Symes amputation has no tarsal bones, but it does have some of the medial and lateral malleoli present. This amputation is really nice because it can provide a patient with a longer lever arm that allows them to have increased control. They can typically bear weight on the end of it. However, the bulbous end, that doesn't show well, but you can see the bulbous end here. I'm sure Dr. Childers has told you, but it can be difficult to find or create a optimal prosthetic design. Frequently, you're going to have a BOA system or some type of system that allows for the limb to get into the socket but accommodate for this fleshier or bulbous distal end. The distal end can also be a tricky fit with the limited componentry that we have. It can be hard to find a prosthetic foot with a low enough build height. So you can see right here, this is the ProSimes from Autobach, and prosthetic design or foot design has gotten increasingly better as the years have gone by. So this has a very low build height. But say, for example, we had a big carbon fiber foot that went up, let's say, 6 inches off the ground, but you only have 3 inches from, the bottom of the person's amputation to the ground. What are you going to do? Because if you put them on a foot that is too high, we know that this could cause the pelvis not to be level, cause extreme hip and back pain that can lead to scoliosis or other issues. Okay, hopefully that makes sense. All right, so here's a brief overview again at the amputations. There's two other, the Boyd and the Pyrgoff, but these aren't commonly as talked about in the text. I know that they definitely are, but frequently they will cut the calcaneus in different portions and have it attached back up, just depending on how severe the amputation is, what the surgeon prefers. So go and check these out and be a little bit familiar with these, but there are alternatives in how they do amputations besides the ones we just talked about. So these two are pretty interesting, especially the Pyrgoff one. So we have discussed why a longer limb provides leverage, and that leverage is beneficial for control. But what are some other reasons you can think of why a partial foot might be considered beneficial to a more proximal amputation? So why would we have a Symes? Why would maybe a Symes be a good thing rather than a transtibial amputation? Alright, so one reason is that the plantar surface of the foot has thick skin. Remember, it has that extra layer of stratum lucidum, so it's not as sensitive or as fragile as the skin on a transtibial or transfemoral amputation that is not accustomed or useful for being a weight-tolerant surface. So the skin is thinner, it's a little bit more fragile as well, and it's going to have pretty much a surface that's not used to bearing weight on it, and putting weight on that makes the tissue subject to ulceration, blisters, uncomfortable rubbing, things like that. So what else? What other benefits do we have to having a partial foot or a Symes amputation? All right, if we have a hind foot, we can provide greater energy conservation when compared to higher levels of amputation generally. But there are some disadvantages, of course, in having a partial foot compared to another amputation, and again, that was more than likely componentry or getting an optimal fit. Also, we have limited push-off the more proximal the amputation, so if we have a transmetatarsal, we have a little bit more push-off, a little bit less strain on our tarsal bones than compared to a Liz Franck. Okay, but regardless, be sure that you know the pros and cons of partial feet and amputations, okay?